Good evening, everybody. Welcome to this evening episode of Pursue. And this is Pursue Phase 3. In this Phase 3, we would be having recorded lectures. And as you must be aware that Neuropath lectures are now available in YouTube and they are freely downloadable and they are there to stay. We also have a Telegram group where you can join and get all the updates regarding activities of Neuropath lectures. And we have the Google Drive where all the PDF of all the lectures are available, and you have the master integration key through which you can navigate to all the PDF as well as the YouTubes in one go and in a very easy mode. So these are the disclaimers. With all this, we are starting phase 3 on the 1st of March today, 2023. Unlike the previous two phases, this is a recorded pathology lecture phase, which is convenient for the teachers, for the students, as well as for us, the organizers. And to start with phase 3, we have the first lecture from Kolkata, IPGMER. And to talk on that, we have Dr. Shristi Butta, who is an MBBS honors gold medalist, MD pathology from IPGMER. She's presently a demonstrator in the Oncopathology unit of the Department of Pathology at IPGMER SSKM Hospital, Kolkata. She has got 12 publications in national and international journals, with special interest in neuropathology, molecular genetics, and hematopathology. And today, we are starting with the very basics in neuropathology, which is histology of nervous system. And then subsequently, we will be covering various aspects of CNS. And Dr. Butta will be taking more lectures on that. With this, I hand over the mic to Dr. Butta to start her lecture and wish her best of luck. Thank you so much.
A very good morning. We are all set to start our Neuropathology Module 1, which is Neurohistology. So what do we plan to talk today? We plan to discuss the cerebral and the cerebellar cortex, the types of cells present, what are the basic components of the neuronal cytoskeleton and how alterations of some of these components are associated with neurodegenerative diseases, the use of silver stain in the histological study of CNS, GFAP as a key protein in the diagnosis and identification of astrocytes and astrocytic disorders, myelin formation and cells making myelin in the CNS and PNS. And finally, what is the role of microglia in the CNS inflammation and repair? So let's start. The parenchymal cells of the central nervous system are neurons and glia. The important cell types to examine are neurons, particularly the cerebral cortical pyramidal neurons, note pyramidal neurons, oligodendroglia, astrocytes, and ependymal cells. Now, cortex is precisely a slightly paler region as compared to the subcortical white matter, which is comparatively deeply staining. Now, this is a diagram showing the layers of the meninges, which is the inner pia, the middle arachnoid, and the outer is the thicker dura, which is not shown in the diagram. The subarachnoid space is particularly rich in the arachnoidal vessels, and that makes it somewhat spongy. What about this diagram? This diagram illustrates the 6 specific layers that are present in the cerebral cortex. What are the cells present there? Pyramidal cells, spiny stellate cells, and the non-spiny stellate cells, which particularly are composed of the basket cells and the chandelier cells. Now coming to the pyramidal cells. These are flask-shaped cells or triangular cells with apical, single or multiple basal dendrites. Most form majority of the projection neurons. So these cells are the basic components of the cerebral cortex. Coming to the spiny stellate cells, most of these are multipolar. They are relatively smaller in size and have spiny dendrites. Their axons ramify within this grey matter in a vertical plane. So let's see. The cerebral cortex typically has the molecular layer, which is composed of the axons and dendrites, the external granular layer, which has the densely packed stellate cells with small pyramidal cells, external pyramidal cells, which is the layer number 3, composed of medium-sized pyramidal cells and mainly loosely packed stellate cells, layer 4, which is densely packed stellate cells only, layer 5, which has large pyramidal cells only, that is the giant pyramidal cells or the bed cells for that matter, and the layer 6, which is composed of multiple sized pyramidal cells and loosely packed stellate cells. So now look at this diagram. What do you see here? You see a cell body, the axon and the dendrites with the particular dendritic spine. There are two types of neurons which have been shown here. One is the pyramidal neurons, okay, which typically has a triangular body, and the nucleus has a vesicular chromatin with prominent nucleoli. Okay, and there is an interneuron stellate cell which is present. Now coming to the subcortex. The subcortical white matter is largely composed of axons and oligodendroglia. Typically very important, the subcortical white matter is composed of oligodendroglia. Now these oligodendroglial cells typically have a fried egg appearance. Now this is very important because when diagnosing a tumor that is an oligodendroglioma, you will see particularly a rich population of these cells. In addition, in oligodendroglioma, there will also be chicken wire vasculature and microcalcifications. Okay, so now restricting ourselves to the histology, this is the subcortical white matter where you have the fried egg appearance that is seen of oligodendroglial cells and the blood vessels. The central nervous system or the CNS particularly is rich in neurons and glia. The glial cells are composed of astrocytes, oligodendroglial cells, ependymal cells and microglia. The fibrillary matrix of the cerebral grey matter, that is the neuropil. What is it composed of? It is formed of cellular extensions of the neurons and the glial cells. The neuropil is traversed by blood vessels. As leptomeningeal vessels penetrate the brain, the subarachnoid space, remember the subarachnoid space dips into the CNS tissue around them and creates what is called as a perivascular clear space or the Verco-Robin space. So what do you see here? You see the different types of neurons and the glia. Okay, you see the microglia. You also see the oligodendrocytes, okay, which are typically interested in producing what is called as the myelin sheath. Now what about this picture? What do we see typically here? We see the neuropil. Okay, the neuropil is nothing but the cellular extensions. Okay, and we also see the glial cells and the neurons. This is another picture of the oligodendroglia. Now what about this picture? We characteristically see the blood vessels and the surrounding space around the blood vessels is the Verco-Robin space. Now each neuron has particularly a cell body, the perikaryon, and axon and the dendrites. The dendritic tree is the receptive part of the neuron. The axon conveys the signal to its target. The motor neurons, which is the largest cell in the CNS and has a cell body size of about 135 micron, granular neurons of the cerebellum, which are smallest and have a size of about 4 micron. Scattered in the cytoplasm of these neurons, what do you have? They have ribosomes and rough endoplasmic reticulum, which is typically called as the nissl body or the nissl substance. So this is a picture of a spinal motor neuron with abundant rough endoplasmic reticulum, which forms aggregates. And the blue things that you see here, okay, what are they? They are nothing but your, yes, they are the nissl granules. Okay, let me just show it to you with a laser pointer. Here it is. So what do you see here? These are your nissl granules, right? Okay. If the axon is transected, okay, the rough endoplasmic reticulum disaggregates and the neuronal body balloons. Let's see how does that happen. Yeah, so here you have a picture. Okay, the cytoplasm has become smooth and the nucleus has been pushed to the periphery. Okay, this characteristic appearance is called as central chromatolysis. It is a reversible change that typically develops during repair of a neuron that has been disconnected from its target. Neuron with central chromatolysis has been shown in the left lower corner, and the rough endoplasmic reticulum has disaggregated, okay, and that has resulted in neuronal body ballooning. And what do you see here? These are the 3 normal neurons, right, with lots of nissl substance in the cytoplasm. That is nothing but the rough endoplasmic reticulum. Mitochondrial disorders cause neuronal loss and present as encephalopathy, myoclonus, and strokes. So remember, this neuronal loss is typically seen in mitochondrial disorders. Hypoxia, ischemia, and hypoglycemia cause irreversible neuronal injury. Injured neurons shrink in size and become eosinophilic. Okay, so look at this neuron. This has become eosinophilic. And what about the nucleus? The nucleus has undergone condensation. Okay, so there is a condensed nucleus that you see here. Okay, and this nucleus has become pycnotic, right? Why is this becoming pink, the cytoplasm? Because of the condensation of the mitochondria. So you have a condensed nucleus and a condensed cytoplasm. Condensed nucleus resulting in a pycnotic nuclei and condensed cytoplasm resulting from condensation of the mitochondria, giving it a characteristic eosinophilic appearance. Such neurons are referred to as axonic neurons, right? Neurons contain numerous lysosomes that are used for lifelong recycling of biomolecules and organelles. Deficiency of lysosomal enzymes, especially in lysosomal storage disorders, has been encountered, and that results in accumulation of unrecycled substrates of these enzymes. Abnormal lysosomes gradually fill the cell body and processes, leading to destruction of neurons. So this is a neuron that you see, and distended within it are the lysosomal substrates, okay, resulting from deficiency of lysosomal enzymes. So this is a algorithm which shows the lysosomal storage disorder and the different types of it: the Tay-Sachs disease, the Fabry's disease, the Gaucher's disease, Niemann-Pick, Krabs, and metachromatic leukodystrophy. Tay-Sachs disease typically results from deficiency of hexosaminidase A. Fabry's disease from deficiency of alpha-galactosidase A. Gaucher's disease resulting in accumulation of glucocerebrosides results from deficiency of glucocerebrosidase. Niemann-Pick disease, which typically results due to deficiency of sphingomyelinase, and results in accumulation of sphingomyelin. Krabs disease, on the other hand, results from deficiency of galactocerebrosidase and there is accumulation of galactocerebroside. Metachromatic leukodystrophy is characterized by accumulation of sulfatides due to deficiency of aryl sulfatase A. Now, the neuronal perikaryon and processes contain longitudinally arranged 10 nanometer intermediate filaments. So, as we all know, intermediate filaments are characteristically present within the cytoplasm. So, these intermediate filaments within the neuronal perikaryon are referred to as neurofilaments, and the 20 to 26 nanometer tubules are called as the neurotubules. These neurotubules and neurofilaments form a characteristic lattice, okay, and that gives the cytoskeleton support. In Alzheimer's disease, these neurotubules and neurofilaments form a tangle which is referred to as neurofibrillary tangle. So these are the neurofibrillary tangles which are characteristically seen in a patient with Alzheimer's disease. The most important part of the neuronal membrane are the synapses, as we all know. Most synapses develop on thorn-like processes of dendrites, the dendritic spines. Each synapse consists of, what does it consist of? It consists of the axonal terminal, the synaptic cleft, and the postsynaptic part of a dendrite. Okay. The most important excitatory neurotransmitter is the glutamate, and the most important inhibitory neurotransmitter is the gamma aminobutyric acid or the GABA. So look at this picture. It gives you a diagrammatic representation of a synapse with the axon terminal, synaptic cleft, and the dendrite. Now, the hematoxylin and eosin, that is HNE, is adequate for the routine staining of the cellular details of neurons and glial cells, but does not stain the neuronal processes. Okay, that is, the axons and the dendrites need to be demonstrated with the help of silver stain, in which the ammoniacal silver is deposited on the cytoskeleton component and then is reduced to the black metallic silver. Right? The most commonly used silver stain is the Bielchowski staining protocol, which is used for axons and dendrites, which shows the normal axons and dendrites and also reveals the lesions, especially in Alzheimer's disease. The generic term, that is the degeneration, that is the striatonigral degeneration. We will be having a complete discussion of the neuronal and its associated disorders in the subsequent lectures, okay, and in the subsequent modules. So these degenerations mean a gradual neuronal atrophy leading to neuronal loss. So such a process characterizes most neurodegenerative diseases like the Alzheimer's disease and the Parkinson's disease, as we all know. In others also, there is only neuronal loss and brain atrophy and gliosis. But Alzheimer's and Parkinson's, besides the neuronal loss, brain atrophy and gliosis, also have characteristic histopathological changes which will be discussed in the subsequent modules. Now coming to neuronal plasticity. What does this mean? Neuronal plasticity refers to a change of the neuronal structure or function dependent on the activity. Neuronal activity changes with density of the dendritic spines. For example, resumption of function of speaking in a patient who was having a stroke, say for example. So if he resumes speaking function, then what happens there is that the group of neurons which were dedicated for speaking were lost in stroke. Due to stroke, as a result, the person had stopped speaking. Subsequently, another group of neurons takes up the function and now the person starts speaking. So this typical phenomenon of acquiring a function, okay, in a particular set of neurons is referred to as neuronal plasticity. Astrocytes. Now, what are these astrocytes? As we all know, as the name implies, these are star-shaped cells and their cytoplasm contains intermediate filaments, okay, which are referred to as those filaments which are rich in glial fibrillary acidic protein. Okay, so this is a GFAP, and this GFAP has highlighted the star-like astrocyte. During brain development, the astrocytic processes, that is the radial glia, guide the neurons in their migration from the walls of the ventricles to the cortex. Radial glia are also a source of neuronal and astrocytic stem cells. So that is typically important in the development of the brain. Astrocytic processes are intertwined with neurons and axons and myelin. They cover the dendrites and the synapses. They surround the brain capillaries. Interdigitating astrocytic processes also form a thick layer on the CNS, which is called as the glia limitans. So this is a thick layer, as you can see. Okay, I'll be just highlighting it with a laser pointer. Okay, so this is the layer that you see. Okay, and what is this layer? This is the glia limitans. This is nothing but the interdigitating astrocytic process. So this layer seals the surface of the CNS and dips into the brain tissue along the perivascular Werco-Robin space. So remember the clear space around the blood vessels? So glia limitans is the thick layer of interdigitating astrocytic processes on the surface of the cortex, and the molecular layer underneath. Okay, so this is the molecular layer that is underneath, and what does this contain? This contains mainly synapses. Astrocytic foot process. Now, what is the significant importance of this? Astrocytic foot processes surround the brain capillaries and during development induce endothelial cells to form what is called as the tight junction. So look at this. This is the astrocytic end process here. End feet of the astrocyte, and these are the endothelial cells. So endothelial tight junctions are found mainly in the brain capillaries, right? So these astrocytic processes induce the endothelial cells to form what is called as the tight junctions. So these are the tight junctions that you see, which forms the basis of the blood-brain barrier, right? Loss of the integrity of endothelial barrier causes fluids to leak into the interstitial space here, leading to what is called as vasogenic cerebral edema, right? Astrocytes are, however, less vulnerable than neurons to ischemic injury, but they are damaged if there is lactic acidosis. Such damage of the neurons causes intracellular fluid accumulation, resulting in what is called as cytotoxic edema. Cytotoxic edema involves the cerebral cortex, whereas vasogenic edema is more pronounced mainly in the white matter. The small amount of glycogen that is present in the astrocytes is, however, the only source of stored energy in the CNS and can be used when neuron activity demands. More important, the coupling of the astrocyte to the synapse and the vessels facilitates the entry of the glucose into the CNS in response to neuronal activity. They take up and recycle GABA and glutamate, okay, that are released at the synaptic cleft. So that is important. There is recycling of both the excitatory and inhibitory neurotransmitter. When neurons are lost, okay, brain tissue is damaged due to several causes. Astrocytes proliferate, and that results in what is called as gliosis. Okay, so that particularly results in the development of reactive astrocytes Okay, so what is very important here is the phenomenon of astrogliosis or gliosis, which involves the proliferation and hypertrophy of the astrocytes, and also there is upregulation of GFAP. So this is very important to note. Why? Because when we are diagnosing a tumor, typically a diffuse astrocytoma, we need to differentiate it from gliosis, which is nothing but a reactive process which occurs due to neuron loss. Astrocytes participating in gliosis are referred to as reactive astrocytes. They have large cytoplasmic mass, long branching processes, and increased cytoplasmic intermediate filaments, that is GFAP. Such astrocytes are referred to as gemistocytic astrocytes or gemistocytes for that matter. In hepatic encephalopathy, ammonia is taken up by the astrocytes and is converted to osmotically active glutamine, which causes cytotoxic astrocytic swelling. Okay, so what does that result in? It results in what is called as the type 2 astrocytes. Now these type 2 astrocytes, okay, which are very significantly and typically associated with hepatic encephalopathy, are nothing but swollen astrocytes. Their nuclei are large and appear clear on H&E. Type 2 astrocytes show a nuclear enlargement which is more than 2 times that of the oligodendrocyte, and the chromatin margination is typically appreciated. A similar change develops in hypoxia and ischemia as well. So you have aquaporin 4 or the AQP4 channel, which is the most abundant water channel in the CSF. Now this channel is located typically in the astrocytes. Okay. Now this is located in the astrocytic membrane facing the blood-brain and the brain-CSF interface. I'll be showing you the diagram in just a bit. In neuromyelitis optica, that is NMO, there are IgG autoantibody production which elicits an inflammatory reaction, and that destroys the AQP4 channel, leading to disruption of the blood-brain barrier, oligodendrocyte loss, and demyelination. Antibodies to GFAP are also responsible for autoimmune GFAP astropathy, and that also typically results in destruction of this aquaporin 4 or the AQP4 channel. Now, where is this channel located? As I've already said, these channels are typically located in the astrocytic membrane. Okay, they function basically in maintaining brain water homeostasis between blood, cell, interstitial fluid, and ventricular cerebrospinal fluid. Now, what are Rosenthal fibers? Rosenthal fibers are homogeneous eosinophilic elongated or globular inclusions in the astrocytic processes. They have a filamentous and granular structure and contain what is called as GFAP. Mutations of GFAP have been noted in Alexander disease, which is characterized by diffuse and dense deposition of these Rosenthal fibers, resulting in white matter destruction and neuronal dysfunction. The Rosenthal fibers in Alexander disease contain mutant GFAP and also other proteins which are also mutant. But however, mutant GFAP is typically characteristic of Alexander disease. Now, what are these? These are the Rosenthal fibers. They are homogeneous, eosinophilic, elongated, and globular inclusions in the astrocytic process. So let me just show it to you, okay, with a pointer. Yes, so these are the homogeneous eosinophilic inclusions, right? So these are all Rosenthal fibers. These Rosenthal fibers are typically important when you're diagnosing a pilocytic astrocytoma, which is typically seen in the children and the adolescent age group. Now coming to the oligodendroglia, myelin is a sheath of plasma membrane wrapped around the axon, right? It's an insulating myelin sheath that is produced by none other than the oligodendroglia. Okay, what does this myelin consist of? It consists of 70 to 80% lipids and 20% structural proteins, typically the proteolipid, myelin basic protein, and myelin associated glycoprotein. In the CNS, myelin is produced by oligodendroglia, whereas in the peripheral nervous system, it is produced by the Schwann cells. So what do you see here? You see these oligodendrocytes, as I've already discussed, they have a characteristic fried egg appearance and they must be easily identified, typically in cases where you have an oligodendroglioma. Okay, so to differentiate a normal oligodendrocyte from a oligodendroglioma, which also in addition has chicken wire vasculature and microcalcifications. Most myelin stains use hematoxylin-based solutions that attach to the phospholipid component of the myelin sheath and gives myelin a deep blue color. Myelin and oligodendrocytes are non-specifically lost in cerebral infarcts, infections, and other lesions that involves the white matter. Okay. They are especially sensitive to hypoxia and ischemia in premature infants. So oligodendrocyte injury has been noted in perinatal period in the white matter infarcts or permanent white matter infarct loss. Okay, in cases typically like the periventricular leukomalacia. Luxol fast blue is the one which stains the myelin. So this is the Luxol fast blue dye, okay, which is typically staining your myelin. Oligodendrocyte loss occurs in demyelinative disorders such as multiple sclerosis and progressive multifocal leukodystrophy. Now, PML or the progressive multifocal leukodystrophy is a condition which is caused by the papovavirus, and this virus typically infects the oligodendrocytes. So, myelin proteins are immunogenic and some aspects of inflammatory demyelinative disorders are due to the autoimmunity produced by these viruses. Leukodystrophies are metabolic disorders caused by biochemical abnormalities of the myelin lipids and proteins. They show diffuse and progressive loss of myelin. The term degeneration in reference to myelin means loss of myelin. In reference to white matter or specific tracts, it means loss of myelin and axons. Okay, so we will be discussing it in the subsequent modules. Ependyma. Now, what are these ependymal cells? They are nothing but the ciliated epithelial cells that develop from the radial glia along the surface of the ventricles of the brain and the spinal canal. The ependymal cells line the walls of the ventricles and form the specialized choroid plexus epithelium, which typically secretes the cerebrospinal fluid. The ependymal lining can be injured and lost as a result of infections involving the cerebral ventricles, that is the ventriculitis and the intraventricular hemorrhage. Residual ependymal cells proliferate and form rosettes, okay, and small nodules of reactive astrocytes, okay, can also be produced, and these are then referred to as ependymal granulations in the walls of the ventricles. So let's show a picture of this ependymal granulation to you. Now, what is this? There is sloughing of the epithelium. So the ependymal cells have been lost here. Loss of the ependymal cells due to sloughing, followed by a small nodule that develops underneath, composed of typically astrocytes. Now, this phenomenon is referred to as formation of ependymal granulations, right? Okay, let's move on. Brain monocyte macrophage cells. The brain contains two sets of monocyte macrophage cells, parenchymal microglial cells and the blood-borne monocytes. Now, what are these microglial cells? The parenchymal microglial cells are mesodermally derived cells which enter the brain early in gestation and comprise approximately 12% of cells in the brain, okay, and they're more abundant in the gray matter. Their function is typically to phagocytose neurons that undergo programmed death during development. So this is a cluster of microglial cells and lymphocytes, okay, and this is typically forming what is called as the microglial nodule. Okay, let's see further. In the resting form, the microglia are inconspicuous. They have an elongated nuclei and small amount of cytoplasm with short processes. Microglial cells have receptors that enable them to sense the damaged tissue and to recognize viruses, environmental and endogenous toxins and other pathogens, and such recognition leads to upregulation of these microglial cells, right? So activated microglial cells become rod-shaped, okay, and have a greatly ramified cytoplasm. They encircle this degenerating neuron here, and this phenomenon is referred to as neuronophagia, right? Okay. So they encircle the degenerating neurons, and this phenomenon is called neuronophagia, and also forms clusters, okay, around small foci of necrotic brain tissue, and that is called as the microglial nodule. Perivascular monocytes. Perivascular monocytes reside typically in the perivascular location, that is just outside the vascular basement membrane. These cells are the main antigen presenting cells of the CNS, thus playing an important role in the immune reactions involving the brain. They, along with the CD4 lymphocytes, are also the main cells that bring HIV into the brain. So that is typically important. Perivascular monocytes can later on transform to macrophages. Okay, so this is just a representation that you see of the capillary lumen. Okay, the characteristic endothelial cell lining those lumen, the tight junctions that are present, the basement membrane, the pericytes that you see. You also see the microglia, the perivascular macrophages or the monocytes, which later on change into macrophages. Okay, and you also see the neurons and the interneurons. Now coming to cerebellum. Normal cerebellum is shown here. Okay, and this is the low power magnification, while this is the high power magnification. Now look at this folia here. The folia typically has the dark blue granular cell layer and the pink layer, that is the molecular layer. And then there are scattered Purkinje bodies, Purkinje cell bodies. So what do you see here? This is the pink layer or the molecular layer. Okay, these are the Purkinje cell dendrites that you see. These are the Purkinje layer, which is composed of the Purkinje cell bodies, and this is the granular cell layer composed of granular neurons, which are typically very small, and as we have discussed, they are 4 micron in size. Cerebellar cortex has 3 important layers, right? The outer molecular layer, the middle Purkinje layer, and the inner granular layer. The outer molecular layer mostly has neurons and some unmyelinated fibers. The central layer is composed of the Purkinje cells, whereas the inner layer has very small neurons, that is the granular neurons. So this is what it is, and subsequently you have the white matter here. Then again you have the granular cell layer, Purkinje layer, and the molecular layer. Okay. So concluding, neurohistology forms the basis of neuropathology. Surgical neuropathology can be rather challenging due to intrinsic complexity of the human brain. Yet, a basic understanding of the cell types and their organization is therefore necessary. Much like the pattern recognition used in classifying diseases, so too can normal histology be approached based on the tissue pattern recognition. So what are the key takeaways for today? Yes, stick to your basics and keep things simple. Thank you so much for your patient hearing.
Thank you, Dr. Butta, for such a wonderful presentation. It is very essential for us to understand the histology of the CNS before trying to understand the pathology. And it was a very lucid, very nice presentation, and it will be very helpful for all the students as well as other people who will be listening to this lecture to understand the basic histology and then to go on to understand the pathology. Thank you. Fine. Good night, everybody. Take care. Bye.